So for this, we take our tuning fork. This is, of course, going to be the Rhine test. And we would hit it and ring, place it on the bone in the back, and it would ring, and the patient would hear it. When they stopped hearing it, in this case the patient will simulate, I stopped hearing it.
I stopped hearing it.
We would bring it out and put it in front of the ear, okay? And the patient should then still be able to hear it at this point, okay? If they can still hear it here after they've lost being able to hear it from its initial position, it tells you that air conduction is greater than bone conduction. In a patient with hearing loss, very often the sound would still travel through the bone, and then when you brought it out here, they would not be able to hear it, okay? And that would be indicative of at least unilateral hearing loss, and if it's repeated on the other side, it could be bilateral hearing loss. So we would conduct this test on both sides. Again, ring on the back, that's bone conduction. She stops hearing it, I bring it to the front, she can still hear it, and that indicates to me that air conduction is greater than bone conduction. Next, we will do the Weber test, and that is where we hit the tuning fork again, we place it on the top of the head, allowing the sound to travel down through the bones. The patient should hear both sides unilaterally, or excuse me, both sides equally. If there is hearing loss on one side, the patient will hear the bone conduction better on that side. Because the air conduction on that side is weaker, the patient will hear the bone conduction. So again, tuning fork to the head, you're looking for an equal hearing on both sides that lasts the same amount of time. And again, gives us a window into the air conduction versus bone conduction. Next, we were going to look using the otoscope at the patient's tympanic membrane. So we will visualize the structures of the inner ear. You shine the light in, you see the white light reflex. You will see the tympanic membrane, and it should not be bulging, it should not be red, it should not be ruptured, certainly. You're going to look for cerumen, the amount of it, if it's impacted, of course foreign objects, and the structures of the inner ear itself, the inca, the malleus, the small bones that help us hear. Even without the otoscope here, you can see with light into the patient's ear. And while not fully visualizing the tympanic membrane, you can see that there's not excess cerumen, there's not redness, there's not discharge. And very often in patients who are having respiratory infections involving their sinuses or their ear, that very active manipulating their ear will be painful. And again, no pain exhibited here. So it's another signal to me that confirms my initial assessment that there's no issues with the ear and that the patient can hear. Next, we are going to move on to the neck. So in this case, we'll start with flexion, extension, and rotation of the neck. So first I want you to put your head to your chest and all the way back like this. Okay, and then move it midline, and move it down to your left, and then to your right. Okay? Any issues or pain with that?
No.
Okay. So now we'll try that against resistance. Can you press this way against my hand? Okay. Now press this way against my hand. Okay. So the strength was equal bilaterally, and again, no pain, no problems with the patient doing that. Next we will try to have the patient shrug your shoulders. Okay, so that tells me the cranial nerve 11 is intact, and the shoulder rise was equal. Again, no pain, no abnormal findings at that point. Next, we are going to palpate the patient's thyroid. So we'll briefly move around back, and you're going to locate the thyroid, which is behind the trachea. And this technique will involve the patient. You're looking for the borders right now. You're not always able to palpate the thyroid borders in a healthy patient. In assisting in getting, helping us find the thyroid, we're going to have the patient swallow a drink of water. And as she did, I just briefly displaced her trachea using my right hand to the left, and I found the border of her thyroid. And I'm going to have her drink another drink of water. And again, I displaced it now with my left hand to the right, and I was able to find the border of the thyroid where the head would be. Again, it's not really palpable in this patient unless you briefly displace it. Was that painful?
No.
Okay. So no pain, and the thyroid borders. it can be a normal finding, or excuse me, it is normal to be able to palpate them and not indicative of any negative condition or malady. So we are going to now test the lymph nodes, and what we do is we move down through in the preauricular and the postauricular and the occipital and the submandibular. And again, having known this patient, typically, unless she has an active infection, you can't palpate her lymph nodes, which is normal. Some people, especially in the deep cervical or supraclavicular chain, can have mobile nodes that you can feel. Like the superficial cervical here, I can feel a couple mobile nodes here as I palpate down, and that's a normal finding. That's fine. And then we will look for the deep cervical. Behind the sternocleidomastoid muscle, you get a pinching motion and sort of displace the sternocleidomastoid muscle, and you can feel the deep cervical. And the same on the left side. And now the supraclavicular. And just while we're on the lymph nodes, I'm going to go to the epitrochlear now, so that we don't forget. All right? And I'm not able to palpate on this patient, but again, that's where past history comes in, because typically, unless she has an active infection, you cannot palpate her lymph nodes. So nothing there. Okay? Next, we are going to examine reflexes of the arms and continue with our cardiovascular assessment. So what I'm going to have you do is extend your arms out, bring them back in. Now against resistance. Okay, now against resistance. Okay, equal bilaterally. Any pain, any problems there?
No.
Okay. Can you move your arms out to the side? Okay, and down. Against resistance. Okay, and against resistance. Okay. Equal and no pain, no issues there. With your wrists, I want you to go up and down with your wrists. Okay, now against resistance. Okay, and against resistance. All right, and can you kind of rotate your wrists? And no pain there?
No.
Okay. And that would be indicative of pain in the small joints here. Could be arthritis, could be a structural bone damage, and would indicate further evaluation. We're looking for inversion and eversion there, which she demonstrated without any issues. Next, we're going to examine the pulses. Positive. Nice positive, +2 pulses. And you can perform an Allen's test, including both. And the hand turns white, and you release the inner, and the blood flow comes back. That tells me she's getting circulation from both the inner and outer aspect of her arm. We're going to check the brachial pulse. Okay. Again, +2, easily palpable, regular rhythm. And we'll include both. The hand turns white, we release the other. And again, good collateral circulation. And lastly, we're going to palpate the carotid pulses. Nice, easy, +2 bounding. Everything is normal, which is what you expect from a patient this age. And while we're here, we're going to assess for a carotid bruit. So no bruit left, and no bruit right. And bruits would typically be associated with patients who are older and have smoked and present a higher risk of stroke and issues with orthostatic hypotension, as the stenosis in the carotid arteries can affect the vasovagal reflexes of the patient and their ability to compensate from position changes. So in your geriatric population, it's something that you're going to want to be aware of, and you're more likely to find an abnormal finding. Next, we're going to have the patient turn around and sit. Thank you. And again, that simple motion is part of our evaluation of her musculoskeletal system and neurological system. By doing that, it indicates to us that the patient is intact in those ways. We'll still assess, but it's a good indication that things are moving smoothly. So from here, I can see that as the patient breathes, the chest is, the posterior is moving in unison, that her spine is midline. You go through and you palpate every single junction, noting for pain. No pain. Okay? Alright, the spine is midline, I can feel it. And as she breathes, everything moves up consensually. In a patient whose left shoulder was higher than the right, or vice versa, you could consider some sort of spinal abnormality or a structural shoulder dysfunction. In a youthful patient, a child, you would be concerned for scoliosis if you had a finding where one shoulder was above the other. And that would need to be further assessed. So we are going to then palpate for CVA tenderness. This is something where, have you had any issues with urination or burning or pain with urination?
No.
No recent fevers?
No.
You always want to assess for that before you palpate for CVA tenderness, because with somebody with kidney inflammation, it can be extremely painful, this assessment. So you simply put your hand over the kidney, above the iliac crest, and just a little closer to midline, and no reaction. In a patient who had kidney inflammation, kidney stones, or any kind of pyelonephritis, things in this family, they would frankly jump through the roof. So again, on this side, pound, okay, and no reaction for the patient. As you can see, her posture is good and even, and no jumping, so no CVA tenderness. So what we're going to do now is just observe the skin. The skin is clean and intact. There's no obvious maladies. Again, as I showed before, the spine is midline. And we will start assessing for tactile fremitus and observing respirations. So what we will do is have the patient say 99.
99. 99. 99. 99. 99.
Okay. So there was no consolidation. The 99s were even throughout. So if there was a fluid deposit, such as in the case of a respiratory infection, or a density of a mass, it would change the way that the 99s felt through to my hands, and in this case there was none of that. Now we will try to percuss to see for changes. So the percussion is a little bit denser over areas of bone mass, and more tympanic over areas between the ribs, in the space between the ribs. So next, so that was palpating for resonance as well as diaphragmatic excursion. As you can see, when the lungs expand and come out, you're going to find the borders, and the borders of this patient's lungs were exactly where they should be. There was no adventitious sounds as far as when we were palpating, or excuse me, when we were percussing. Deep breath. 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 Okay, so the lungs were clear to auscultation at all points. You could hear adventitious breath sounds if a patient, for example, had crackles down here. That would be indicative of fluid moving up, as in case of congestive heart failure. If there was wheezing, that could be associated with symptoms like conditions like asthma. But everything was equal throughout, and the patient was breathing easily and moving up and down. The posterior chest was moving up and down in unison, telling us that everything was functioning correctly. So that's the posterior assessment. So now we're going to turn the patient around. I'm just gonna ignore her. If you can't hear, our baby's crying in the background, so we're deciding whether or not to continue the exam or to get the baby. So you can figure out with us here as we go. About 5 minutes.
Okay.
Yeah. Okay. Next, we're going to examine the posterior chest. And in this case, we are going to examine the skin, which I have. We're simulating it here at this point, where the skin is intact. There's no heaves, abnormal lifting that you wouldn't expect that could be indicative of vascular issues or sort of malformations in the cardiovascular system or problems with respiration. You want to see how the patient breathes. Again, her breathing, everything is moving in unison. In the case of a patient with COPD, they would often use their belly or accessory muscles to breathe as their diaphragm has, the ability of the diaphragm has been overwhelmed to produce respirations. And so we are going to listen to the heart for S1 and S2 and any kind of abnormal heart sounds. You just breathe normally. And now with the bell. Okay. So S1 and S2 were auscultated at all points. There was no murmurs, there was no S3, there was no friction rub, no gallops, no adventitious heart sounds, again, which is what you would expect in a 37-year-old patient with no history of cardiovascular disease. And now we're going to have the patient lay down and continue our exam. Actually, should we get her?
Probably.
Okay. We're going to take a pause and get the baby, and we'll come right back.